Hello, everybody, and welcome back to another episode in our clinician interview series. And today, I am joined by my friend Louise Donlon. Louise, thank you for joining us here today. I know you're really busy with all your patients in the clinic, so it's really special to have you on the show.
My pleasure. So happy to have.
Alrighty. Well, today we're talking a lot about treating patients with chronic pain and how to help them through whatever they've been going through, whether that's been a year, decades even of pain. But just to get a perspective of your experience, tell me a little bit about how long you've been practicing as a PT and what kinds of patients you've seen over your past years of treatment.
Sure. I've been practicing for just about 24 years and anything outpatient, orthopedic, and sports medicine. So we get a variety of ages and abilities and all kinds of people with different types of pain.
What's been your typical population you see nowadays?
Well, I think we see a good variety of runners here at the clinic. We see a lot of patients with shoulder pain, back pain, knee pain. Those are probably the main ones. People post-surgical, they're just looking to regain their range of motion or strength as well.
Gotcha. So when you are treating patients who are struggling with pain for years, because I feel when you have post-op, it's you have that acute injury, you have a protocol to follow. When a patient comes in and they have a year of, say, chronic low back pain, how do you approach that? What's the sort of approach that you take in just the initial interview with that patient?
Well, I think, first of all, any patient who comes is going to get a very thorough evaluation too, so we can find out what is going on. And some types of back pain, as you know, is non-specific low back pain. So it's not always a specific thing that we say is the cause. It could be emotion or an activity or something. So we try to look at it that way. What makes the pain better? What makes the pain worse? And then with patients with chronic pain, the biggest thing I find is sort of meeting them where they're at. So finding out what they think their pain is coming from. And do they think that because they have pain, it means that something is being damaged? And so trying to sort of meet them where they're at and then bring in the neuroscience of pain education very gradually into the conversation. Because even patients that do have things like spinal stenosis and herniated disc that do cause actual pathoanatomic pain, we know that we can still affect their actual pain experience by educating them on pain science.
Right. And it could be a really tricky topic, too, to broach that, because you could have somebody who also has spinal stenosis, has a bulging disc, and they don't present with the same symptoms. In fact, they could be completely asymptomatic. So I think, even in the patients I've treated, in my past two clinical experiences, it's kind of hard to talk about yes, we've done the image and we've seen that there's nothing that really sort of stands out to those who looked at it, but yet you're still having this pain. And I think, one of the main themes that we've seen in chatting with other clinicians is the importance of validating that pain.
Yes, and that is so key that you say that, because people will say, well, someone told me that the pain is all in my head. Well, pain is always from your head because your brain is the output telling you pain.
Right.
It's how you interpret it, what you do with it. So if I'm sitting here and I'm uncomfortable, and my brain is telling me that's uncomfortable, I can shift positions, I can stand up and walk around. But some people might say, I'm sitting here, my brain is telling me that I'm uncomfortable. That means that I'm damaging my tissue, hurting my back. And then the whole fear process of that leads to maybe I'm not going to go out anymore because I might have to sit at a restaurant where I'm uncomfortable. Or I'm not going to garden anymore because when I bent over once and I did gardening, that caused pain. And it's almost like the Pavlov's dog. If you associate an activity with pain, you're pretty much guaranteed that you will have that painful sort of experience when you do that activity. So part of it's just meeting the patient where they're at. And that what I found over the years is if I've tried to push too much at them at once, or I felt like I can really help this person if I can just get this point across, oftentimes I feel like that has backfired on me. So it's really more meeting the person where they're at, understanding how they perceive their symptoms, their painful experience, and then trying to very slowly help them to sort of move past that in whatever way I can.
Yeah. And it's interesting, you talk about that slow aspect, because I think, when you look at the literature, there's a lot of literature, systematic reviews, meta-analyses that talk about, yes, add in pain science education. Yes, add in sensory motor training. But I feel when you just say just integrate it with activity, integrate it with the exercise interventions, what's not talked about is like that gradual like progression and like how much you tell the person.
Yes. And it's almost like graded exposure to a task. So, for example, if I teach you to do a squat, right now I'm trying to get you to sort of get back to lifting weights again because it was something that you love to do. And I'm teaching you to do a squat, and then you say, oh, it hurts when I get to this point. So then I say, okay, can you adjust your spinal position a little bit? Well, does that feel a little better? Okay, that feels a little bit better. Okay, see, you can still do the squat. You just have to make an adjustment. Or if I lift the 5 pounds, I'm okay. But if I lift the 10 pounds, it hurts. Well, maybe we have to work at the 5 and get your strength a bit better. You can break down the task. But I think sometimes it's just that people get overwhelmed and then they kind of would sort of shut down and associate that squatting task with their pain. So it really is that sort of graded exposure with the education sort of, I think, just so it's very organic. It's mixed in. It's not like, we're going to sit down and have a talk on pain. Because I think sometimes that's a little overwhelming.
Yeah, absolutely. I mean, especially like we looked a little bit at studies that talk about like sort of like these truth statements, like pain is in the brain, which is like, yes, technically that is true, but like,
people can get defensive of that. They think my pain is real, or by say, I had a patient in the past with this type of pain, and then we did this, this, and this, and it improved. And then the patient will come back and say, but my pain is different. My pain is real. Or I have had this imaging that shows I have this. So I've just found being much more gentle in my approach, letting the patient share his or her experience with me, and then I can respond better to that than me. In the beginning, I had all this excitement and education on like all this new pain science, and I just wanted to get it all out there. And I thought, once I get it out there, I'm going to convince these people that they don't have to live in pain and, you know, all this modification of life. But then I realized I was just way too overzealous, and it sort of backfired. And then I've pedaled back so much more and softened it over the years, and I've had much greater results because people want to tell their story and they're expected to be heard. Because so many doctors or other practitioners might say to them like, oh, you're just going to have to live with this, or oh, you should just stop running, or oh, you're getting old, so this, or oh, yeah, you know, how many knee surgeries can you have before you just, you know, have to live with it? And so people have that in their mind as a barrier. Right. And so I think first we have to listen to the patients before, and I've been really practicing that, is the listening. Because like I said, it's much easier I have all this knowledge and I want to share it, but if you don't listen, you can't meet them where they're at.
Right. I mean, it's interesting because like, you know, when somebody comes, I mean, we're talking a lot about like kinesiophobia as if we're putting a name to it, like that fear of that movement. And I think a lot of what you're talking about of like saying like, not just, oh, they have fear of movement. And I think doctors that just don't move, you are actually like, what are you doing? And like, can we adjust it?
And also, it's like if you put your hand on a hot stove once and you got burned, your brain's going to tell you, don't do that, or at least think about it before you do it because you may get burned.
It's a protective response.
Right. So for example, if someone said to me, I stood and cooked for 4 hours on Thanksgiving and my back was so painful that I couldn't go to work for 2 weeks. So now I don't cook anymore. Well, okay, let's break down what actually happened. Maybe you overdid it. Maybe you over shoveled. Maybe you overcooked. Maybe you over gardened. And that doesn't mean that the task itself is bad. Maybe you just did a bit too much of it and you weren't prepared. So I think it comes down to just like breaking it down, meeting the person with that, listening to what their pain experience is, and validating that. Like, yes, that was a traumatic thing. Now look at how great your brain is. It's trying to protect you from possibly having this experience again. Now you have to decide what to do with that information that your brain is giving you.
Yeah. No, absolutely. And I think you saying like you have to decide, that's like such a critical piece of putting the like, you know, we're not fixing patients ourselves. Like we're empowering them to like to have the tools.
And you're also like, you have the knowledge of that, and we have a really good photograph and an explanation of like that tissue tolerance.
Yeah.
So it's like, sometimes I'll get a memory of a neck issue that I had in the past, and it will sort of stop me, and I'll remember, oh, when I had that disc thing in my neck, I felt that. And then I have to say, okay, calm down. Like, you didn't do this, the things that triggered it in the past. Your neck is a little sore. You maybe overdid it lifting. Okay. And I have to talk myself back from that experience. Yeah. That's what we're trying to get our patients to do. We're trying to get them to do, okay, this is a bad idea. I probably shouldn't do this. Or, okay, I'm going to be fine. I can do this, but I have to do this, this, and that. So it's really processing the information that your brain is giving you and then making a decision based on that information. What's the best course of action here?
Yeah. No, I'm kind of curious because, like, we can talk a lot about like that initial conversation of like reframing and helping them to break an exercise down or an activity. But like, how does that conversation evolve? Like, what does like an initial conversation look like at first when you're kind of breaking down an exercise, but then later on when you've worked with this patient for maybe like several months, do you still have those conversations? Do you still find you have to reiterate those concepts?
So I think in the beginning, it's building the therapeutic alliance. Like when someone comes to you, especially those patients that have had, like you say, pain for long periods of time, maybe they've gone to other practitioners or physicians, and they just want someone to say like, I really care to help you make this get better. And I really think I can help you feel better and have a better quality of life. So I think right away, I find the patients will kind of like exhale, like, so thank you so much for like listening to me and wanting to help me. So I think that's a really good start. And I think you're right. You have to, along the way, it's like baby steps. So I think of like a patient who just came to us that we saw who hurt his knee at the gym by lifting too heavy of a weight. And then was afraid to go back to the weightlifting. And so each time we saw him, we did a little more, a little more. And whereas the last time he was here, we did 75% of his prior weight and had no pain. So he felt like, okay, I can go back and do this on my own. And I just kept saying to him, like, it's just baby steps along the way. Little by little, you get back. And so I think it's like that. You could break down sort of any big task with that. And then those patients who have that severe anxiety and severe avoidance, those are the people you think of sending to, like, we're so lucky to have here BU Center for Anxiety and Related Disorders. So we could then send them to someone who deals with that anxiety or those fears that surround things if we just can't get past a certain roadblock. We have options of that.
Yeah, and that's a tricky line to kind of walk along too, because I feel like we have such a holistic experience or like a holistic education. And so like understanding like, oh, like when that severe anxiety comes in, like it's like, oh man, this might be a little too much for me. But knowing that referral source, like we're lucky to have CARP.
They're amazing.
It's amazing, right? But
and it's
like,
very structured, like sort of program. So I think it goes nicely with what we do as well, kind of in tandem sometimes. And I think, again, it's before you can sort of broach that, you have to have that therapeutic alliance. Because if someone comes in and I just say, I think you need to go to CARD, it's not a great way to start. So I think it's just more just very gradual, lots of listening, and then for me to process what the person is saying and then kind of go in very gently, which I've learned to be more gentle in my approach over the years, because sometimes, like I said, I've tried too hard, and that may be a patient that just like doesn't come back. When we think like, I keep all this great education, and now the patient's like, she doesn't believe me in my pain experience, or she doesn't understand me because I really have damage here or something like that. So, and the hardest patients of that are the ones that identify themselves through their pain. So it's like, I can't work because of my ankle. I can't socialize because of my neck. And they're spending a lot of time going to their doctors, and they're really not spending time doing anything that they love. So they wouldn't just say, I am a 40-year-old female. They would say, I am a 40-year-old female with back pain that limits my life. And they're on support groups. And those are the hardest patients to treat, because their identity is wrapped up in their pain experience. So breaking down those barriers becomes much more challenging, because they may not have a life outside of their EDS support group, So those are the most challenging patients that I found to treat over the years. And that takes just a lot of, they need to see results. So that becomes the art and the science where it really mixes together, because that comes with what exercises do you start these patients on that have good sort of results in the literature, and that you've had good results with, that actually help people to feel better.
Yeah.
And then they start to trust you, like, I actually felt a little better when I left. And so then you can slowly get to that. So it's the physical and the psychological.
Yeah, because it's like you can't just be like, oh, I'm just gonna adjust the biomechanics of your exercise and that should make things feel better. Like you have to like do a dual pronged approach.
I think so.
Yeah, and I think so. I guess I want to learn a little bit more, like an example of what you're talking about. Of like you try like an exercise and you like what results do you look at and like show to the patient even, you know?
So I can think of a couple people, like I've had referrals for patients with like chronic pain, for example, and they come from like a pain clinic. And so they've gone to many physical therapists, many doctors, and there's injections, all kinds of things. And for example, like we have had in the past a SwimX pool here.
Right.
With like, so it's like warm water. They can exercise at different levels of body weight based on how deep the water is. So I can tell that patient, I've had people come to me just like you, and I put them in the pool, and guess what happens? They feel better. So I feel confident that I can help you to feel less pain if we do this and this, because I've had this happen in the past. And here's the evidence on aquatic therapy for patients with Ehlers-Danlos or arthritis or something like that. And they start to perk up and listen, like, you can help me? Because obviously they want to get better. That's why they're coming, right? So if you can say, I've had very good success with this, they're willing to try. And if they then see, wow, I felt better for the rest of the day after I left Louise in the pool that day, oh, I'll come back. So now you're already starting to have a positive impact because they believe you that they might be able to feel better, even though it's only maybe it's going to be for 6 hours. But if they do it 3 times a week, 45 minutes, maybe they have pain the next day. And then maybe they start to feel better and better. So then I think that's how I tell them, you know, this is the literature. This is the experience that I've had with my patients. And would you be willing to give it a try?
Yeah. I think that's a good point too. It's like that setting expectations, you know, like where you're not going to have this quick fix, especially if it's something that's like you talked about, like if it's really their identity, like I am a person with low back pain, like that's not an overnight thing. And being honest with that patient and be like, you might feel better, like for a day, you might feel a comeback, but let's try this over time.
Correct.
Keep talking with me about it. Like, and I think that could be tricky too, because, you know, I feel like you can't get like the perfect intervention on that first like few days. Like,
oh no, it's a process. And you have to be upfront with them day one and you say, okay, you've had this pain for X months or X years. It's certainly not going to be an overnight, you know, it's not like a light switch goes off and it's like, oh wow, I feel better. It's very a gradual process.
Yeah. I kind of told I remember this past summer, I would be telling patients going, all right, first day, this is our, we're going to do a lot of trial and error. We're going to experiment together.
Yeah.
Like, we're going to work on this. I have ideas based on like past patients similar to you, but I don't know if this will work.
Yes. And I love that approach.
Let's work together.
Let's work together on this. And you tell me, and I'll say like, based on my evaluation findings, this is where I think we should start. If it's too easy, if it's too hard, if it doesn't, let me know. And we'll work on it. Because sometimes patients will just like suffer in silence. They'll just like do the exercises you gave them. And then they'll go home and say, I felt terrible after that. I'm like, gosh, why didn't you tell me while you were doing it that it didn't feel great, you know? So they think, oh, just because you said to do it, I'll do it. So I think it definitely is very collaborative. It empowers the patient as well.
Absolutely. And I think even too, it's like, why didn't you tell me? It's like, okay, like I think even me was like, and I say that, I'm like, why didn't you tell me? I'm also asking myself, like, why didn't it ask? Well, and it's like, that's the idea of like, don't, you know, sometimes that it's important for us to take a step back too and say like, oh gosh, okay, maybe I need to take a different approach. Maybe I was like, because they're not telling me for some reason, you know.
Correct.
What can I do to to establish that relationship better?
Well, one thing I really learned from COVID, when we had to pivot and do like telemedicine, when you were like one-on-one with your patient, there was no distraction. It was like you were listening to everything they were saying, and it really made me value more the things we tell the patients. The education.
Yeah.
Almost as much as the things we do.
Yeah.
The exercises and the manual intervention, because it's so powerful, the words we choose.
Yeah.
And when we choose to say them, and also looking at the patient to find out how the patient is receiving the information. Because just because we're saying it, like in the clinic too, it's easy with all the distraction. But like when you're like looking at the patient in the Zoom camera, you can see if they're rolling the eyes or kind of like, oh, I'm not really sure. So that really made me become a better listener, I think, because I really had that one-on-one, no distraction to think like, I know what I'm saying, but I want to really know how it's being perceived.
Yeah. And that's that listening to understand versus just like listening and be like, okay, now I can respond with this. It's like, yeah, that's trickier.
It's trickier.
Yeah. No, it's definitely like, I think, there's like a lot of like in the past times when we would be doing like PT, like we would be seeing like, okay, what is their diagnosis? Like, it's like, oh, this is a fibromyalgia diagnosis. This is like low back pain diagnosis. And I think like, we're starting to move away just generally as a profession from just, oh, like this diagnosis results in this kind of treatment. And it's more of, what are they doing? Like, what is their activity? Regardless of their diagnosis, how do we help them adjust and like...
Right. Well, it's always patient-centered care.
Exactly.
Right? So it's like, if I'm doing some silly little exercise, like, for a runner, and I'm doing standing clamshells or side stepping, and the person's like, why do you have me doing this silly exercise? They like then starting to say, this ties to your functional goal. This is how this ties to your functional goal.
Yeah.
So all the things we do are the patient-centered care tying to their functional goals, because that's why they're here, because they want to pick up their kids or they want to run that half marathon or whatever they want to do. And we have to keep pulling it back to why we're educating them, why we're doing exercises, why we're doing, modification of activity. It's all to help them get to their functional goal.
Yeah, and I think that's why I like the patient-specific functional scale.
Love it.
I just feel like that particular scale works particularly for this kind of population because, I mean, there's others too. Like the Ostro Y app is really great for giving you a general like yellow flag. Because are you familiar with the Ostro?
No.
So it's like it's a outcome measure that gives you an estimate based on different yellow flags of like depression, anxiety that can be measured on other outcome measures as well.
Oh.
So it's kind of like a nice sort of like almost like a quick shotgun approach to tell you, okay, like what are some main areas that might need to be addressed that are more like yellow flags, like not just nociceptive kinds of pain, but what are some things that might hint at like more psychosocial issues and more
like we use the start back
Yeah.
a little bit, but maybe
Another
it's a little bit more specific.
Yeah, and the research around it, like it's a little bit more new. But we were talking about it at CSM, and it was kind of nice to kind of say like, oh, like what are ways in which we can sort of frame our approach, like early on.
Based on it. Oh, interesting. So I'll just show me that after.
You should talk to Lee, honestly. Lee's one of the professors in the program, and like she's talked to us about it in classes. So
I definitely will.
Yeah. Okay, so we are running low on time, so I think one of the last few things I just like want to ask about, two things. I want to touch on 2 points. The first one, so we've looked a little bit at like mindfulness, and like that kind of like like mindfulness-based therapy. How often are you kind of incorporating aspects like that into your like therapy like sessions?
Do you mean like meditation?
Yeah, like because there's research behind it, but and there's also been a little bit of conflict as to like whether there's meaningful changes. Do you find yourself using that in practice?
I haven't really used it. I tend to use a lot of aerobic exercise for pain reduction, like global exercise, and specifically having people go outside and try to do it in nature when they can, because I feel like there is sort of that, I guess you could call it mindfulness, which is a meditative relaxation. But I haven't gotten too much into like the specific. I know there's like apps that we've tried in the past and things like that, but I haven't really delved into that aspect yet too much.
I mean, honestly, that's something where I'm like, man, I'm not as familiar about it either. So I'm like, man, do I need to like start looking into this more, even for myself?
Yes.
I feel like everybody could use it. But I think the second thing, like as like a way to just kind of cap off the conversation, I think what's like one story that has stuck with you in treating somebody who's struggled with chronic pain? Like is there a specific patient that really sticks in your mind in terms of like how you helped them and you're like, wow, that's
yeah,
special.
it's funny that you say that, because the second you mentioned it, I thought of this woman who came to me for her shoulder. And then as we were talking, she started telling me about other things that were hurting her. And then she sort of confided that she was a real estate agent and she's pretty much like disabled. She really can't work because she has all this pain. And every time she would go to a doctor, they would say, basically, like, there's something mentally wrong with you. Like, you're fine. We can't find anything wrong. Well, I had said to her, you kind of fit the profile of someone with a hypermobility syndrome. And I think that's probably why you have all this pain. And she literally burst into tears and said, you are the first person who has ever taken me seriously. And we treated her shoulder, and then I helped her get in to see sort of a specialist to get a diagnosis. And she was like on the path to getting back to like living a life that had the quality that she was like looking for, just because I sort of listened to her. And so that always comes back to me, that one person. And literally, like, I've had other patients like that too, who say, you just took the time to listen to everything, all my history. And so I think that's what kind of comes to my mind. And I can think of a few patients like that with all different body parts and different types of pain. But sometimes in the medical community, there's a specialist for the shoulder and a specialist for the knee and for the neck. But there's not someone that puts it all together as one person with like experience of life. And so that's one thing I feel like as a profession, I think that we as physical therapists do a really good job at that. Is really treating like the whole person. And I think the pain, science is like such a huge and exciting part of like what we do now too. And the research is evolving. It's always getting better and better.
It really is. I mean, there's even been some recent like clinical trials. There's like Resolve trials that came out. And actually, I think the clinic here talked about it in an in-service recently.
Yes. And we're going to get to talk with a very exciting researcher coming in a couple of weeks. Yeah, it's such a treat to hear him talk. They're so passionate about it, and they really are changing the world. It's just one patient experience at a time. It's really fun to be a part of it.
I think back to his TED talk. Like, I actually have it as like one of my bookmarks in my browser. It's like, talk about like pain. Is it all just in your head, or is it something real? So it's great. Alrighty. Well, that is all the time we have today. But Louise, thank you for joining us on today.
It's a pleasure. Thank you for taking the time to ask me. It was fun to share it with my experiences with you.
It was fun. But honestly, like, I hope you all enjoyed it as well. Stay tuned. We've had 5 people on the show so far, but hey, we're hoping to have a few more. But we'll see you next time. Make sure to like, subscribe, and follow all of our channels. And we hope you have a great rest of your day or night. Take care, everybody.